Hi, my name is Bruce Potenza. I'd like to welcome you to today's educational module presented by the Division of Trauma, Critical Care, and Burn Surgery here at the University of California, San Diego. Our educational module that we'll be talking about today includes the initial management of burns. There are about 2 million people that are burned in the United States every year. 80% of these have relatively small burns, encompassing less than 20% of the total body surface area. About 75,000 patients require hospitalization for these burns, but 20,000 of these patients require care at the nation's burn care centers. If we look at how we've improved in the care of our patient over time, if we compare 1952 to 1993, if we look at what the lethal dose of a total body surface area burn was in the 0 to 14 age range, 49% total body surface area burn resulted in a 50% mortality in 1952. In 1993, it was a 98% burn that resulted in a 50% mortality rate. Great improvement, great strides in critical care of pediatric patients. Unfortunately, as patients get older, we don't see the same improvement in the survival. It's only a 10% burn in 1952 that resulted in 50% mortality of our patients. And that improved modestly just to 25% total body surface area burns in 1993, still resulting in a 50% mortality. It's the comorbid diseases of these patients that tend to cause their ultimate demise and not the burn. The burn just seems to exacerbate the underlying comorbid cardiac and pulmonary disease, resulting in multi-system organ failure and death. If we look at the different types, etiologic types of burns, we see the most common types of burns changes by age groups. In the pediatric group, scalds are the most common forms of burns that we see. As children get older, they begin to play with gasoline and flame and matches and begin to be burned by fire. In the workplace, we see a great number of electrical burns that are seen by workmen. We see structural fires. In the United States, structural fires are the leading cause of death, and the structural fires is that of a house fire. And if we look on this side of the slide, we see multiple other etiologic types of burns that we deal with. Here is a classic example of a catastrophic burn that included great amounts of thermal entry as well as kinetic energy, which resulted in explosions, blast injuries, and ultimate collapses of these buildings. Had these buildings not collapsed, the amount of burn patients that the city of New York and the United States would have had to have taken care of would have been astronomical. It certainly would have taxed the entire country's system of taking care of burn patients. What are the important questions that you want to ask your patients when they come into your emergency department or to your primary care clinic? What you want to know, importantly, is where did the burn occur? Did it occur inside a closed space or did it occur outside? That's important because if it occurred in a closed space, it tends to be a hotter fire, and the potential for secondary smoke inhalation injury is omnipresent. In open space fire, the fire tends not to be quite as hot because it's dissipated in the open spaces, and the incidence of smoke inhalation is markedly decreased in an open space fire, but does not approach zero. Then we want to know what was the etiologic agent that caused this, and if it was a flame, was the patient actually on fire? Did their clothing caught fire, or did they just graze up against the fire? Patients who have a history of actually being on fire, their clothes on fire, are generally going to have deep second-degree burns, or partial thickness burns, or full thickness burn. And we also want to know what type of flame was involved. Is this a wood fire? Is this a coal fire? Is this a gasoline fire? Is this a kerosene fire? Because all these fires burn at different thermal levels, and the amount of heat that's generated and is absorbed by the skin times the time it was in contact with the skin determine our depth of burn in our patients. And we also want to know the length of time that the patient was exposed to the burn. And importantly, as your paramedics bring the patient in or the patient self-presents, we want to know what was done to take care of the burn at the time of injury. As I mentioned earlier, 73% of all of our fatalities in the United States are due to structural fires, and that major structure is in the home. And most of these patients die because of smoke inhalation, not because of their burns. They're only secondarily burned. So smoke alarms, smoke detector, carbon monoxide detectors are the key preventive issue here in trying to decrease the amount of fatalities and injuries that we see due to structural fires. If you look here, 12 patients die every day due to a house fire. An automobile fire is a very significant fire because this tends to be a very hot fire. The patient's in a confined area. The fuel that's in the automobile is very flammable. If your patient has a history of needing extrication from a motor vehicle crash which resulted in a fire, expect the worst. This patient is very likely to have a third-degree burn and probably has a significant component of smoke inhalation. Expect this when you hear your patient was in a motor vehicle fire. Let's talk for a minute and just review the different types of burn wounds by depth. Conventional layman's terms talks in first degree, second degree, third degree, and fourth degree. We'll talk in partial thickness versus full thickness. So there's a superficial partial thickness burn, which involves the epidermis of the skin and the superficial dermis, and there's a deep partial thickness burn that involves the deeper dermis. Third degree extends all the way through the epidermis, both layers of the dermis, and extends down to the subcutaneous fat layer. Fourth degree goes into the fat layer and then extends potentially deeper into muscle and fat. If we look here, we have a layer of keratinocytes, followed by the layer of epithelium, followed by a layer of dermis. What we see here are arrows depicting different layers and depths of burns. We also have hair follicles that you see here and sebaceous gland here. These are all lined with epithelium, and that's the significance of these because they provide islands of regrowth for the epithelium in a patient who has a burn injury. This is just another schematic here looking at a superficial partial thickness burn, a deeper partial thickness burn versus a full thickness burn. Here's an example of someone who has a first degree burn, which is typically discussed as being that of a sunburn. Remember, some patients who have very light skin or have been out in the sun for long periods of time can present with sunburn that includes the development of vesicles, bullae, or blisters in lay terms. This is a second degree burn by definition when we see those things present. The fact that the mechanism of injury was just the sun does not always mean that it's going to be a simple first degree burn. Here's a typical scald pull-down injury that we see with children. The child probably pulled some hot water or coffee off a table. It ran down his chin and down the anterior torso. Very typical look, not usually associated with child abuse, but with a careless event that the child has now experienced by a simple pull-down injury. This is a very common mechanism of injury in the young children less than 3 years of age. Here's a deeper partial thickness burn. You can see here that it's not as shiny, it's not as wet appearing, it's a little bit drier. This wouldn't blanch as well as our prior picture would, and this represents just a deeper layer of involvement of the dermis of the patient. This may or may not heal with conventional conservative methods, or it may require some surgery. Here you can see a typical full thickness flame burn. This is a patient laying on the side, the head is in this position. You can see the flame characteristics in the burning that's on the skin. What we also see here are evidence of how deep the burn is, with evidence of some of the veins which have actually thrombosed being visible in this picture. Another picture looking at full thickness burns, and what you see demonstrated here is just how some of the patient's clothing, the straps of the upper clothing and the straps of the pant legs, actually decreasing the amount of thermal injury that the patient has in that area. Also notice that the axillary areas are spared. Well, what's important or what's different about burns compared to other types of injuries? Well, there's a phenomenon called burn shock, and burn shock is just a demonstration of a systemic inflammatory response to a localized injury. If a patient, for example, is burned in bilateral lower extremities, let's say they have a 15% total body surface area burn, the cytokines that are released into circulation from that causes a systemic vasodilatation. With the systemic vasodilation, there's a need for increased fluids and thus the need for a fluid resuscitation formula. A common mistake is thinking that most of the increase of fluids that are required in burn surgery and burn care is due to loss of fluids through the burn themselves. Actually, that's not the case. The case is in the initial resuscitation phase that these patients are third spacing their fluid, similar to what we see in patients who are in septic shock. So the pathophysiology then of burn shock is that a patient, because of their vasodilatation or vasodilation and third spacing of their fluid, develops rapid third spacing body edema. There's an increase in the patient's microvascular permeability that results in fluid loss out of the circulatory volume. Patients become hypotensive as well as tachycardia. We begin to see this type of change in burns that are about 10% or greater. The greater the burn, the more likely this is to occur and the more serious consequences this will have. So burn shock results basically in an alteration of the normal capillary barrier. It results in a widening of the tight junctions within the capillary, a diapedesis of fluid into the interstitium, a reversal of the normal oncotic pressures that usually favor the fluid to stay in the intravascular tree is now actually being favored to move the fluid out of the vascular tree into the interstitium. All these contribute into the third place fluid losses due to burn shock. Here's just a simple schematic drawing where we have tight capillary junctions that are seen here. In burn shock, these junctions begin to widen. We get a diapedesis of fluid and protein into the interstitium, resulting in a decreased circulating volume. As mentioned earlier, the maximum amount of edema occurs for smaller burns in about 8 hours, but in our larger burns it's between 12 and 24 hours and then rapidly diminishes after that, unless the patient goes into a systemic inflammatory response. And this might be seen in a patient who has a combination large burn and a smoke inhalation injury, or it may be seen in a patient who's transferred to your institution who's been under-resuscitated for a number of hours or potentially days. The administration of fluid in the form of a Parkland formula may exacerbate a second hit theory whereby the neutrophils and the leukocytes in the endothelial lining of the vascular tree begin to elicit cytokines, resulting in a very profound vasodilatation and a widening of these tight junctions, which then result in profound fluid loss. In these patients, we might see the systemic inflammatory response last for as long as 3 to 4 days. This is very problematic in patients with large burns who require large surgical excisions of the burn wounds, who are not hemodynamically stable to go to the operating room. It provides a challenge for us to be able to get them to the operating room, excise their burns, and then get them covered transiently. There are a number of different mediators which affect burn shock: histamine, prostaglandins, bradykinins, and catecholamines. All these have their individual and specific roles, but all result in the same: vasodilatation and an increased vascular permeability and secondary third spacing of fluids into the interstitium, resulting in a decrease in the amount of intravascular volume. Additional mechanisms postulated for the mediation of burn shock include oxygen-free radicals. These are actually the real bad actors in burn shock. Superanion oxide as well as hydrogen peroxide is generated, as well as the hydroxyl ion. These not only increase vascular permeability, but these are actually causing cellular destruction and potential cellular death. The faster that we get them out of this, the better off that they are. And the way we get them out of this is to adequately fluid resuscitate our patients. So our goals in fluid resuscitation of the burn patient is to maintain an adequate tissue perfusion that, number one, restores the patient's circulatory volume, but two, on a very regional level increases the perfusion to the areas of burn so that we diminish those areas that are at risk of developing deeper burns or full thickness burns. A burn is very much similar to a cerebral vascular accident or myocardial infarction. There's a central area of tissue that the injury has occurred and for which we cannot change the outcome of that patient. That would reflect an area of death of cells. There's a surrounding area of tissue that, if given adequate perfusion and adequate care, may go on to have a lesser degree of burn or may in fact heal rather than going on via apoptosis to die. And then there's a third area of burn of just at-risk tissue. So again, the goal here is to reestablish adequate perfusion to tissues and diminish the patient's chances of going on and developing a worsening burn. We use the Parkland formula here. We use between 2 and 4 mLs per kg. Sometimes we need to increase this in patients who have combination smoke inhalation and large body burns. Again, our goal is to keep our urinary output between 0.5 ml per kg in an adult and between 1 and 1.5 in children. Specifically though, these are just surrogate markers of perfusion, or reestablishment of perfusion, and need to be used in conjunction with a number of other markers. We use a number of different fluids here as potential resuscitation modalities. For our larger burns, being defined as 20 to 25%, we use a hypertonic resuscitation fluid, which is simply plain lactated ringers, plus 1 ampule, which is 50 milliequivalents of sodium chloride, to give us a sodium concentration of 180 milliequivalents per liter, instead of the usual 135 or 154, depending on whether we're using lactated ringers or normal saline. Hypertonic saline is a 3% solution and is approved, but is not widely used in the burn community at the present time. Colloid resuscitation is not recommended for our burn patients because of the increased width of the gap junctions of the vascular bed, resulting in the diapedesis of both fluid and albumin into the patient's interstitium. So by giving a colloid resuscitation, we may actually be putting more colloid transiently in the intravascular tree and then increasing the amount that's in the interstitium and thus increasing the osmotic drive to pull fluid out of the intravascular tree. As I mentioned earlier, we use the Parkland's formula. An important thing to remember in children, however, is that young children, particularly those who are less than 1 year of age, require glucose as the major substrate for metabolism in their CNS. And without that, they need to rely on ketones. And there are significant adverse sequelae that affect the brain in young children who are running on ketones. So what we do is we always have a glucose solution running at a maintenance IV for the child, and we add our Parkland formula in addition to that, and titrate the Parkland formula to the urine output in our surrogate markers of resuscitation, but always keep our maintenance fluid going, which contains a dextrose solution. In patients who have smaller than a 15% total body surface area burn, pretty much what we're going to give them are just their maintenance fluids. And if they're capable, they'll take oral nutrition at the same time. For patients who are greater than a 15% total body surface area burn, we need to add, in addition to their maintenance fluid, a Parkland formula resuscitation. By the time we reach 20 to 25% total body surface area burns, the amount of maintenance is now calculated within the Parkland formula, and we pretty much are just running a Parkland formula on those patients. Delays in resuscitation have adverse effects in our patient population. First and foremost, those organs which have not been adequately perfused because of a improper resuscitation may have potential adverse sequelae, particularly that when we deal with the kidneys. Patients who have been under-resuscitated may undergo acute tubular necrosis on a prerenal basis. Importantly, at the level of the burn itself, because the patient has been under-resuscitated, those areas of burns which are at risk for ongoing development of ischemia and potential necrosis are likely to do just that. So your potential area of deeper burns is both larger and wider in these particular patients. Of note, in the very large burns, greater than 80% total body surface areas, a delay of resuscitation of only 2 hours results in adverse effects. And one of those we have already mentioned, and that is the second hit theory. The first hit is that there's a priming of neutrophils at the endothelial level due to the initial burn. When there's a delayed resuscitation, when there's ongoing ischemia and anaerobic metabolism, when you then come back and resuscitate these patients, these white cells are primed. And when they're primed and they get the reperfusion, we see essentially a reperfusion injury to the area of ischemia, and the patient develops a systemic inflammatory response. Just like trauma, we resuscitate our patients with 2 large bore peripheral IVs is our first mode of trying to establish reperfusion in them. In burn patients, however, often the bilateral upper extremities and lower extremities are involved in the burn, and so the need for central venous catheterization is a large issue for burn patients. You can use a single or triple lumen catheter. The incidence of thrombosis is higher as the diameter of the catheter increases, but the fact of the matter is plain and simple. The burn patients requiring resuscitation, they're oftentimes requiring sedation in the form of opiates and benzodiazepines if they have larger burns, and so our nurses need access to these patients, and oftentimes the triple lumen catheter is the resuscitation tool of choice. In children who they have significant intravascular volume collapse and intraosseous administration of fluids to reestablish their circulation and then go ahead and get peripheral IVs or central venous catheter is something that must be considered early. Here we see a patient who has an intraosseous catheter. This is placed right here in the tibia. If we were to look, this is the foot. The knee is up here. We are right along the anterior tibia. We are 2 finger breaths, 2 child's finger breaths inferior to the tibial tuberosity. We're using a bone marrow needle, a jam seeding needle. We just by hand push this through the cortex and into the medulla. We aspirate marrow out to verify our position, and then we begin our installation of fluids here. Almost all medications can be given through the intraosseous infusion. One that we don't like to give if we don't have to is bicarbonate, and a second one would be vasopressors. So initially we're able to give volume through the intraosseous infusion, reestablish circulation in the patient, and then go ahead and get the patient a peripheral IV or a central venous catheter. In monitoring our resuscitation, blood pressure and pulse or vital signs is only one aspect of the resuscitation. We want to look at total urine output that the patient's putting out on an hourly basis. We want to look at their mental status and see if that is improving. But we also want to look at their acid-base status as well as surrogate markers of reestablishment of perfusion. These include the normalization of the patient's base deficit, a decrease in the patient's serum lactate levels, and a normalization of the patient's hematocrit level in particular. The hematocrit's a very interesting lab study to follow. On the bigger burns, when the patients come in and you begin the resuscitation, you have a baseline hematocrit level. Very often in the first 6 hours as your resuscitation is starting, you'll see a rise in your hematocrit. For example, if your initial hematocrit was 40, in 6 hours it may be 45. As you begin to catch up with the resuscitation, you begin to see a decrease in the patient's hematocrit, perhaps down to 40. As you continue to resuscitate, their hematocrit usually is slightly lower than their initial hematocrit, perhaps 5 percentage points, and at the end of resuscitation your patient's hematocrit may be 35%. So you see that initial rise in the patient's hematocrit followed by a decrease and a normalization in the hematocrit, and eventually a lower level of hematocrit as you resuscitate. You need to look at all these parameters to make sure you're adequately resuscitating your patients. There are some groups of patients in which urine output is profuse and is misleading. You may see urine outputs 150 and 200 mLs an hour, and the patient is still inadequately resuscitated. CVPs are low, pulses are high, blood pressure is very labile, base deficit is not improving, and hematocrit continues to rise. that should tell you that you're going the wrong way and you need to continue to resuscitate your patient or actually increase your Parkland formula.